An acute kidney injury, also known as acute renal failure, is damage to the kidney. So since it's an acute problem, it's going to happen pretty rapidly. And we commonly see this after prolonged blood pressure or decreased blood volume. And that is because those things decrease blood perfusion to the kidneys. And our kidneys love a good, rich supply of blood. So anytime we take blood away from the kidneys, we're at risk for having kidney injuries. This is also common with the use of nephrotoxic agents because those are harmful or toxic to the kidneys. So things like NSAIDs or certain antibiotics or street drugs can all be nephrotoxic. So when we look at our labs, when we have kidney damage, we're going to look for our GFR, creatinine, and BUN. Our GFR shows how fast our kidneys are filtering out things like fluids, electrolytes, and waste. So if we have sick or injured kidneys, we expect that our kidneys are going to filter slowly. So our GFR would be decreased. And because our GFR is decreased, we can expect that both the creatinine and the BUN, which is our waste products, are going to be increased in the body because the kidneys are not filtering them out as quickly. Can an acute kidney injury be reversible? Yes, with quick intervention, we can absolutely reverse this. We label the cause of an acute kidney injury based on what caused the injury. So we have three options: pre-renal, intrarenal, and post-renal. Pre-renal is going to be something that happens above the level of the kidneys. Intrarenal is going to happen at the level of the kidneys, and post-renal will happen below the level of the kidneys. For a pre-renal AKI, this is when we have a decrease in blood flow to the kidneys. So things like dehydration, heart failure, decreased cardiac output. And what do all of these things have in common is that there is a decrease in perfusion to the kidneys. We expect that the GFR will be decreased, the BUN will then be increased, creatinine also increased. And is this easily reversible? Yes, because it's an acute kidney injury. However, what if we don't treat it? It can progress to chronic kidney disease. Also, anytime you are looking at kidney labs, remember that your GFR will always move in the opposite direction from BUN and creatinine. So if we are filtering more quickly and our GFR goes up, we can expect that our BUN and creatinine, which is our waste product levels, will go down. However, if our filtration rate gets lower and we aren't filtering out waste products as fast, we can expect that the BUN and the creatinine, which are the waste products, are going to increase and that number will get higher. With intrarenal AKIs, the damage is going to be at the level of the kidneys. So again, we have kidney damage, so we can expect that our GFR will be decreased. And because the GFR is decreased, we can expect that the BUN and the creatinine will be increased. Yes, this is easily reversible because it's an acute problem. So if we treat it early, it can be easily reversible. But if it is not treated, it can progress to chronic kidney disease. So an acute problem can always become a chronic problem if it's bad enough or not treated quickly enough. The causes of intrarenal AKI include nephrotoxic drugs, renal trauma, renal diseases like glomerular nephritis, or acute tubular necrosis. With a post-renal AKI, we see damage coming from mechanical obstructions. So this is going to be things like BPH, tumors, stones, trauma, or inflammation. So how do obstructions affect the urine? They're going to decrease the urine output. So this is an acute kidney injury. So again, we have a kidney problem, injury to the kidney. So we can expect that the GFR will be decreased, BUN increased, creatinine also increased. And yes, this is still easily reversible if we treat it quickly because it is an acute kidney injury. However, if we don't treat it, it can progress to chronic kidney disease. Acute kidney injuries are also classified by different phases. We have the oliguric phase, the diuretic phase, and then the recovery phase. In the oliguric phase, your patient is either not going to produce any urine at all, which we would refer to as anuria, or it would be oliguric, where they have very little urine. So very little urine or no urine at all. In this stage, they will produce less than 400 milliliters of urine per day. In the diuretic phase, your patient starts to recover a little bit. Their kidneys are working a little bit better, but they're not fully recovered. So we still have a concentration problem. They're not concentrating the urine well. So we're going to see your patient starts to diurese, which is why it's the diuretic phase, but the balance of things in the urine are not fixed yet. So we have a lot of urine, but not a whole lot of stuff in it. And then finally, we have the recovery phase, where the kidneys are recovered. They're also balancing everything well, and you have a good balance of output with urine and the stuff that's in the urine. At all points of an acute kidney injury, you want to make sure that you are keeping a close eye on intake and output. So strict I&Os, daily weights, and you want to keep an eye on your patient's electrolyte balances with all of these shifts in fluids. So talking a little bit more about these phases. First off, we have the oliguric phase. This is the common initial manifestation of an AKI. How much urine is produced? It's going to be less than 400 milliliters per day. And what's going to affect recovery is how bad the kidney injury was and how quickly it was fixed. We're going to expect the urine-specific gravity to be high. And we're going to expect that your patient is keeping fluid. They're holding on to fluid because they're not putting out the urine. Potassium, we expect them to keep potassium because potassium is hard to filter. So worry about your potassium levels. Make sure you keep a close eye on your labs. If potassium levels are too low or too high, we know we worry about dysrhythmias. So what can happen to the neurostatus? Your patient could experience some altered mental status because they are going to be holding on to toxins. They're not excreting toxins in the urine like they normally would. Also, this is an acute kidney injury, so the kidneys aren't doing all of the things that the kidneys are supposed to do, including balancing the pH. So we're going to worry about your patient going into metabolic acidosis since they're not producing bicarb and not excreting acid. The critical thinking question is, a patient is in the oliguric phase of an acute kidney injury and presents with Kussmaul respirations. ABG results reveal metabolic acidosis. What is the purpose of the Kussmaul respirations? How does this help the body? So what this does is the lungs are coming in to help get rid of acid by increasing the respiratory rate. So you can breathe off more acid quickly to fix the imbalance. In the diuretic phase, we said that we were starting to be able to excrete waste. We're making urine, we're starting to diurese, but we can't concentrate the urine because the nephrons aren't fully functional yet. This phase can last 1 to 3 weeks. And then looking at the urine-specific gravity, we're going to expect the urine-specific gravity to be low because we expect it to be dilute. We have a lot of urine, but not a lot of stuff in it. So why should the nurse be concerned about electrolytes? It's because your patient is diuresing, and we do know that when you are urinating, you do lose some electrolytes in the urine. Also, watch your patient's daily weights and I&Os with these quick fluid shifts. 1 liter of fluid is the equivalent to 2.2 pounds. So you can always tell how much your patient is losing based on their daily weights. Remember, weight does change very quickly in these types of circumstances. In the recovery phase, we have the return to normal urine output. The kidneys are healing, they're doing their job again, they're excreting urine, and they're concentrating it appropriately. It can take up to a full year for all of this to fully stabilize. So now that we're in the recovery phase, let's look at what we expect our labs to be. The kidneys are healed. So we expect that our GFR is going to be better. And if our GFR is better, that means it's increased because it's filtering quickly. And if our filtration rate increased and we're filtering waste out faster, we expect that our BUN and our creatinine are going to decrease and go back to their normal baseline. So again, what happens if our AKI is never treated? Remember, you may not get to the recovery phase. You may end up with a chronic kidney problem. The overall outcome for your patient is going to depend on their health, the severity of the problem, and what complications they experienced. When treating an acute kidney injury, we want to eliminate the cause, manage the signs and symptoms, and prevent complications. Remember, most of those complications are going to be related to fluid balance and the electrolytes. So we want to make sure we are fixing our fluid balance. We were holding on to fluid. So typically we will give these patients a diuretic. We also want to fix the high potassium and the high phosphorus levels. Since the kidneys typically have trouble excreting those, we expect that they'll be high, and if they are, we can give some medications to decrease those levels. We also want to renally dose meds, so we will adjust the dosage of medications based on the patient's current renal function. For diet considerations, these patients are going to be placed on a fluid restriction, which is typically 1 liter to 1.5 liters per day. We also want to keep them on a low sodium diet because if we have them eating a whole bunch of foods full of sodium, that's going to keep even more fluid in their body. Remember, sodium and fluid go hand in hand. They stick together. We're also going to want to limit their potassium, their protein, and their phosphorus. And that is because those are all things that are very hard for the kidneys to filter and excrete. So we've limited a bunch of stuff for these patients, but they do have to get nutrition from somewhere. So what we'll do is we'll tell them to be on a high carb diet. Patients at risk for an acute kidney injury are the elderly because there's a natural decline in organ function, patients who have chronic kidney disease because they are always at risk because kidneys are already damaged, massive trauma, that could be a direct injury to the kidney, or massive trauma in the sense of blood loss to where we decrease perfusion to the kidneys, cardiac failure, again, decreased perfusion to the kidneys. We worry about patients with sepsis because if you have a septic patient, those patients can start experiencing organ damage. We worry about obstructions, and we also worry about nephrotoxic drugs. Looking at the labs on this slide, we can tell that the patient is getting better because we see that their GFR is increasing and their BUN and creatinine are decreasing. Also, their potassium levels were high and now they have returned to the normal range.